السلام عليكم. أنا دكتورة مروة إسماعيل، تدريسية في كلية الطب جامعة الموصل، أخصائية أشعة وسونار. Today we will talk about the heart, the normal and its measurements and the abnormality that happened to it. First of all, we talk about the normal heart. As we know in the anatomy, the heart consists of from the four borders. The right border, which is IVC, right atrium, superior vena cava. Left border consists of left ventricle, left atrium, pulmonary trunk, and arch of aorta. Inferior border from the right ventricle, superior border is the right and left atrium, superior vena cava, ascending aorta, and pulmonary trunk. I mean that the main arteries forming the superior border. The important thing in radiology to measure the cardiothoracic ratio. I mean to measure the cardiac size. The cardiothoracic ratio, we can calculate it from the ratio of cardiac width to thoracic width. What I mean by that? The cardiac width is the distance between the lateral borders of the heart, the most separated borders. Then the thoracic width is the diameter of the thoracic cage from its lateral borders, from the inner wall of the thoracic cage. Then we will divide this cardiac width on the thoracic width. Normally should be less than 50. This ratio should be less than 50%. If it is 50% or more, it's abnormal in adult. While in pediatric, it may reach up to 60% to be normal. So, if it is 50% or more, it's considered abnormal. We should consider at the calculation of the cardiothoracic ratio, it should be the projection will be in PA view. Second, the patient is in erect position and in take a complete breath in, complete inspiration. These three factors are very important in order to make this ratio incorrect. Any of these factors lost, it will make this ratio abnormal, and so the result will be abnormal. Also, it's important that the patient should not be rotated in order to make the correct calculation. The cardiothoracic ratio helps us to decide about the cardiomegaly, or more precisely, the enlargement of cardiac solenoid, because it may be not just the heart itself enlarged, it could be something around it make the cardiac solenoid is enlarged. So this is the importance of the cardiothoracic ratio. So, as from this picture, I will show you how to measure this cardiothoracic ratio, which should be normally less than 50% on PA erect position in full inspiration. We will take a perpendicular line at the lateral borders of the heart, then measure this distance between these two lines. At the same time, we will measure perpendicular lines at the thoracic cage from the inner wall and the distance between this. Then we will divide this distance above this distance. It should be less than 50%. This is a CT of the heart. Make a subtraction, show us the heart only and the thoracic cage. This is the normal cardiac solenoid size, while this, if we make a perpendicular line from this and measure this distance above this distance, it will be more than 50%. So we will have cardiomegaly or enlarged cardiac size. So, if enlarged of cardiac solenoid on the chest X-ray, what does this mean? We have four causes of this. Either cardiomegaly, which is the most common cause, or pericardial effusion, the anterior mediastinal mass, or prominent epicardial fat pad. Now we will talk on each topics, what we mean by that. Causes of cardiomegaly, we have an mitral valve disease, the most common, congestive heart failure, congenital heart disease, the most common is TOF, tetralogy of Fallot and Epstein anomaly. Now we talk about the mitral valve disease. Mitral valve disease mean we have to take the features of mitral regard or mitral regurgitation. On typical radiograph, the feature of the mitral regard on the frontal projection, I mean by PA, is the left atrial enlargement. Second, double density sign. Third, elevation of the left main bronchus and splank of carina. Fourth, the upper zone venous enlargement due to pulmonary venous hypertension. Fifth, left ventricular enlargement. And sixth, feature of pulmonary edema may also present. The left atrial enlargement, it will cause a convexity or straightening of the left heart border. As we know, in normal heart, we have concavity of the left heart border. When the left atrium enlarged, it will cause either straightening of the left heart border, as is this picture, straightening of the left heart border, or convexity. This is because the left atrial is enlarged. Second, we have double density sign. The double density sign, we mean that there is enlargement of the left atrium. It will cause a projection or a compression of the adjacent lung, and this will cause a double contour of the heart, as this of the right heart border, double contour. Third, we have splaying of the carina and elevation of the left main bronchus because of the left atrial enlargement. We have upper zone venous enlargement due to pulmonary venous hypertension, upward diversion of the pulmonary venous. We have left ventricular enlargement. This occurs when due to volume overload, due to regurgitation. And lastly, we have features of pulmonary edema, this of the late stages. This is the upward diversion of the pulmonary venous. This is another picture. We have straightening of the left heart border. We have double density of the right border. We have upward diversion of the pulmonary veins. Here we have starting the pulmonary edema, congestion of the hilum, and enlargement of the left ventricle. As this is. So the cardiac size will be enlarged. This is the site of the surgery of the mitral valve. Second things of cardiomegaly is congestive heart failure. Congestive heart failure are either left or right heart failure or both. The most common is the left-sided heart failure. This will present a feature of pulmonary edema. What I mean by pulmonary edema? Pulmonary edema, we see the central pulmonary venous congestion, I mean by prominent hilum, civilization of pulmonary vein, what's the upper loop pulmonary venous diversion, and pulmonary interstitial edema is the septal lines, pulmonary alveolar edema, cardiomegaly, and pleural effusion. So what I mean by septal lines? Septal lines, I mean by that it's the curly lines, which is the interlobular septa become filled with fluid in the pulmonary interstitium, causes these lines. This occur when there is the pulmonary capillary wedge pressure reach between 20 to 25 millimeter mercury. We have four types of curly lines or septal lines. We have curly A lines, which are 2 to 6 cm, oblique lines that are less than 1 millimeter in thickness and course toward the hilum. I mean it's central and start the hilum to reach up, go to upward to the upper lobes. Curly boy lines is 1 to 2 cm lines seen at the periphery of the lung, which are perpendicular to the pleural surface. So it's peripheral. We have curly C lines. These are short lines, not reach the pleura as in B or D lines, and not course from the hilum, so it's not A line. Seen within the tissue of the lung, not periphery and not central. Curly D lines is the same as curly B, I mean by its periphery and reaching the pleura, but seen only on the lateral view in the retrosternal air gap. This picture, we see the lines, for example, C line, we have B line, here a line from the hilum, and this is the interstitial edema because the fluid collected in the interstitium make these septal lines. If the pressure increased more than 25 millimeter mercury, we see the following findings. There will be increase in the cardiothoracic shadow, or ratio, sorry. There will be pulmonary alveolar edema. This will be presented in bat wing sign. This is bat wings. We will see the septal lines in addition to the previous, as we say. We may see the pleural effusion. There will be central pulmonary venous engorgement due to congestion, and in addition to the upward diversion of the pulmonary venous to the upward due to seeking for air because of a lot of fluid in the scene in the base of the lung due to congestion. So from this picture we see signs of the heart failure. We see that there is upper zone diversion of the venous. We have pulmonary edema. We have slightly pleural effusion. We see that this is the B lines, curly B line here, and increased cardio as we measure 18/30 of the thoracic. We have more than 50%, which is the increased cardiothoracic ratio. I mean by cardiomegaly. This is the alveolar pulmonary edema in a bat wings feature. This is just like a bat wings distribution. This is the very congested lung field, very tired patient. There is alveolar and pulmonary edema and interstitial. All these feature even pleural effusion with the cardiac increase the cardiac size. Now the second cause of the increased cardiac solute is the pericardial effusion. Here with the heart by itself is normal size, but there's a fluid around it, make the cardiac solute is enlarged. Normally, as we know, that there is in the pericardial sac we have 30 to 50 ml of fluid. Normally, this prevents the friction of the heart with the pericardial sac. The very small pericardial effusion cannot be seen on the plain radiograph. We need to amount the fluid to be more than 20 ml of fluid in the pericardial sac in order to be visible radiographically. The feature that appear on the plain radiograph, the heart will be globular enlargement of the cardiac shadow, giving the appearance of water bottle configuration, or what's called globe-shaped heart or pumpkin-shaped heart. We will see in this picture. The cardiac enlargement will be globular in size. How we know that this is not just cardiomegaly? If we make a line in the center of the chest, we will have if you make a line on the center of the chest, this line will divide the cardiac solute equally. I mean the right equal to the left. This means that there is diffuse enlargement of the cardiac solute. This is the cause of pericardial effusion, in addition to just a water bottle sign or globular sign. This is the CT scan of the chest on axial section of mediastinal window. We see the heart is normal size, but there is pericardial effusion in the pericardial sac. The last topics about the increase of the increased cardiac solute is the cause of congenital heart disease. As we know, the congenital heart disease, we have a cyanotic congenital heart disease and uncyanotic congenital heart disease. In the cyanotic heart disease, congenital heart disease, we have divided it either to increase or decrease pulmonary vascularity. About the increased pulmonary vascularity in cyanotic congenital heart disease, we have total anomalous pulmonary venous return, transposition of great arteries, TGA, truncus arteriosus, large AVSD, single ventricle without pulmonary stenosis. About the decreased pulmonary vascularity in cyanotic congenital heart disease, we have TOF, this is the most common, tetralogy of Fallot, pentalogy of Cantrell. We have maybe Epstein anomaly with ASD. About acyanotic congenital heart disease, we have either that increase pulmonary vascularity or that do not. About the increased pulmonary vascularity, we have VSD, ASD, AVSD, patent ductus arteriosus PDA. While if normal pulmonary vascularity means small shunts, like aortic valve stenosis, aortic coarctation, pulmonary stenosis. Now I'll talk about each one in short notes. Regarding tetralogy of Fallot's, it's the most common cyanotic congenital heart disease that causes decreased vascularity of the lung. We have the VSD. We have right ventricular outflow obstruction due to pulmonary stenosis, pulmonary artery stenosis. We have overriding aorta and right ventricular hypertrophy. So what this will show us on the plain film? This will cause the heart to be in boot-shaped heart. What's it mean? That there is upturned cardiac apex to the upperward due to right ventricular hypertrophy and concave pulmonary arterial segment because of pulmonary stenosis, and the right ventricle will hypertrophied in order to inject the blood. There will be a boot-shaped heart. There will be pulmonary oligemia because decrease of blood flow to the chest, so we have decreased pulmonary artery flow. We have right-sided aortic arch seen in the 25%. So boot-shaped heart mean tough. This is the boot-shaped heart. Due to right ventricular enlargement, decrease in the size of pulmonary artery, so give this picture. Another topic, we have transposition of the great artery. This is the most common cyanotic congenital cardiac disease. It's make up to 7% of the all congenital cardiac anomaly. What's happened here? We will see that the typical picture of the TGA is egg on a string sign. Egg on a string sign mean as if just like egg on its side. This occur because if we have a narrow superior mediastinum because of changing the configuration of the aortic and pulmonary arterial, so this give this picture. Egg on a string sign. This is the typical picture of TGA. We have VSD. This is among the acyanotic congenital heart disease with the increased blood flow to the lung. VSD, if it is small size, VSD, it will give normal chest radiography. While if you have large VSD, it will cause cardiomegaly because left atrial enlargement. It will cause pulmonary arterial hypertension. It will cause signs of pulmonary edema, as we say previously, and plus minus pleural effusion due to increased pulmonary vascular marking. We have an important topic to talk about it. It's the pulmonary arterial hypertension and pulmonary venous hypertension. What I mean pulmonary arterial hypertension? It's occurred due to resistance in pulmonary artery bed at the arterial level. So this will cause that increase in the size of the right and left main pulmonary artery, while at the same time there will be disproportionately small peripheral vessels. This referred to as pruning of pulmonary arteries. On the chest X-ray, we will see the elevated cardiac apex due to right ventricular hypertrophy. This occurred due to the right ventricle try to pushing the blood against the resistance, so we have hypertrophy. Second, we have enlarged right atrium due to increase of the pressure. We have prominent pulmonary outflow tract, I mean by pulmonary main pulmonary trunk, and enlarged pulmonary artery, I mean by right and left, while there will be pruning of the peripheral pulmonary vessels. I mean that this small peripheral vessels. I mean by pruning, it's just like a cut end of the small parts of the tree, distal parts of the tree. While pulmonary venous hypertension here will occur most commonly, as we say, in the pulmonary edema. Here there will be increase in the pressure of pulmonary capillary wedge. Normal pulmonary capillary wedge is 12 to 14. If this mild elevation, it will cause redistribution of pulmonary flow to the non-dependent lung zone, I mean upper zone of the lung. As we said previously, the upward diversion of the pulmonary venous diversion. While if the pressure increased to approach 20 millimeter mercury, as we say previously, it will cause interstitial edema, pulmonary interstitial edema. While if it is 20 to 25 millimeter mercury, it will cause the alveolar edema and the other features of pulmonary edema. The most common causes of pulmonary venous hypertension, it's obstruction to the left ventricular inflow. Second, left ventricular systolic dysfunction. Third, severe mitral regurg. Fourth, acute pulmonary and systemic volume overload. So the pulmonary venous hypertension, it's nearly equal to the pulmonary edema. See at upward diversion of the pulmonary veins to the non-dependent parts of the lung, and we will see this feature. There is a term Eisenmenger syndrome. It's a complication of uncorrected high flow, high pressure congenital heart disease like chronic large VSD. This will lead to chronic pulmonary arterial hypertension and shunt reversal. It is an important complication of the large VSD, chronic and high flow VSD. It will cause Eisenmenger phenomena with shunt reversal. As we know, in the large VSD, there will be left to right shunt, while in the chronicity, it will cause right to left shunt, from the right side to the left, because of pulmonary arterial hypertension. It's a dangerous phenomenon. The last topic we will talk, very important to consider. We have signs to be seen in the congenital heart, and every sign has its own disease. For example, we have figure of 3 sign seen in co-erectation of the aorta. This is because changing the contour of the arch of the aorta with rib notching, which causes Rosler sign. So it will cause a reverse 3 sign. This is the 3 sign, figure of 3, and the reverse figure of 3. This seen on the aortic coarctation. This is the coarctation. After the aortic arch, after giving the main vessels, it will cause notching of the aorta. So it will cause figure of 3 and reverse 3 sign. We have box-shaped heart. Box shape is occur in Epstein anomaly. Box-shaped hearts seen in Epstein anomaly, I mean by absence of the interarterial and interventricular receptor defect. There is no just a one chamber. The heart, it will be one chamber. It will give a box-shaped heart. Box shape. So box-shaped heart in Epstein anomaly, boot shape, as we said previously in tetralogy of Fallot. String sign is in total transposition of retrograde artery, TGA. And lastly, we have figure of 8 sign or cottage of Loeff's heart in total anomalous pulmonary venous return. This is figure of 8 or snowman sign. This occurs in total anomalous pulmonary venous return because of widening of superior mediastinum and give this appearance of the heart. This is the box shape sign. And thank you very much. Thank you for your listening. I hope that my lecture is clear.